the final one of this hemolytic anemia is going to be the microangiopathic hemolytic anemia. So these are non-immune mediated extracorpuscular diseases, right? So here, as the name suggests, microangiopathic meaning small vessels, and there is going to be some defect in the small vessels causing a hemolytic anemia. So in these diseases, it's not a disease as such, it is a presentation. So many diseases can present with microangiopathic hemolytic anemia. So main ones are HUS, TTP and DIC. So HUS is hemolytic uremic syndrome, TTP is thrombotic thrombocytopenic purpura, while DIC is disseminated intravascular coagulation. So DIC will be studying it in platelets. So HUS and TTP alone we'll see here. So both HUS and TTP, there is going to be some kind of formation of thrombus over here. So in HUS, the cause for thrombus formation is going to be an endothelial injury, while in TTP, the cause for thrombus formation is going to be spontaneous platelet activation. Okay, so let's see what happens. So there is going to be basic pathogenesis. Somehow there is going to be lots of thrombus formation in the small vessels. So when thrombus is going to be formed in the small vessels, obviously it is going to occlude the vessel. So the organ which is going to be supplied by this vessel is not going to be supplied by the blood supply properly. So it is going to result in the infarct in the organ supplied. So in multiple infarcts are going to be present, because it is going to be lots of infarcts are going to be present. So multiple infarcts are going to be present, resulting in organ failure in these conditions. Apart from that, this vessel is going to be occluded by the thrombus, right? So when the blood is flowing through this occluded vessel, especially the RBCs, when it is going to pass through, it is going to undergo a mechanical damage here. So the RBCs are getting fragmented. So they are getting damaged and they are becoming fragmented, and they are called as schistocytes. So formation of fragmented RBCs is going to be there. So that is the second thing. And with the formation of this thrombus, obviously the platelets are being consumed. So there is going to be lots of platelet consumption, resulting in thrombocytopenia. So these three things characterize the pathogenesis of this MAHA. Okay. So there is going to be thrombus leading to consumptive thrombocytopenia, and because of this thrombus formation, there is going to be multiple infarcts, and because of this thrombus formation, there is going to be mechanical damage to the RBCs, resulting in the formation of schistocytes and hemolytic anemia. Okay. So these three are the classical findings in MAHA. So under HUS, what is the cause for this formation of thrombus? So we have two types of HUS, typical and atypical. So typical HUS is the one which is called as diarrhea positive HUS. Atypical is the diarrhea negative HUS. In typical HUS, it is usually a kid, so child presenting with an acute gastroenteritic kind of an episode, presenting with a bloody diarrhea initially. So what is the cause here is there is going to be a infection with E. coli O157H7 strain. So O157H7 strain is going to be there, or a Shigella infection is going to be there. So either of this infection is going to cause an acute gastroenteritis kind of a picture. So both of this is going to produce a toxin. So in Shigella, it is going to be Shiga toxin. In E. coli O157H7, it is going to be a Shiga-like toxin. So either way, this toxin is going to directly go and injure the endothelial cells. So there is going to be endothelial injury, which is the pathogenesis for HUS. So there is going to be endothelial injury. So when endothelial injury is there, obviously the primary platelet plug, so lot of platelet thrombi is going to be formed. So when thrombi is formed, it is going to result in thrombocytopenia. So this thrombi is going to cause multiple organ failure, especially renal failure. So renal system has a specific affinity for this HUS. So renal failure is classical for HUS, and then you are going to have schistocytes which are going to be damaged because of the thrombi, resulting in microangiopathic hemolytic anemia. And in atypical HUS, if you see here, there is going to be deficiency of factor H or factor I or CD46. So CD46, H or factor I is going to be deficient. So all these three are actually negative regulators of alternate complement pathway. So without with the deficiency of these three, it is going to result in inappropriate activation of the alternate complement pathway. So alternate complement pathway is going to be inappropriately activated in this. So when complements are being activated, it is going to injure the endothelial cells here. So the same thing is going to happen. So endothelial injury forms the pathogenesis for this HUS, right? Both here typical and atypical. And renal failure is a classical finding you see here. So clinical features, what will you see? The patient has had a acute gastroenteritis kind of thing. So she might have a bloody diarrhea. Then there can be fever history can be present. Apart from that, thrombocytopenia was there. So thrombocytopenia is going to result in bleeding, petechiae kind of bleeding. So petechiae kind of bleeding is there. So multiple infarcts are going to be there, especially involving the renal system, resulting in renal failure. So there is going to be history of oliguria. And slowly every other organ is going to go into failure. So the patient can have coma or dyspnea. So any kind of multi-organ failures can be there. Then microangiopathic hemolytic anemia is there, right? So the patient will present with anemia and anemia related heart failure also, right? So this is related to HUS. Then seeing TTP. So TTP is thrombotic thrombocytopenic purpura. So as the name suggests, there is going to be presence of thrombus formation here. And there is going to be thrombocytopenia because platelets are being consumed in this formation of thrombosis. And because of decreased platelet count, there is going to be purpuric presentation, right? Here actually, the defect is going to be in a deficiency of a protein called as ADAMTS13. So ADAMTS13 is an enzyme actually. It is going to normally what happens is ADAMTS13 is responsible for cleaving the von Willebrand factor. So when von Willebrand factors are going, they tend to form multimers, right? Von Willebrand factors. So in order to stop that, you'll have, this is a regulatory kind of an enzyme. So this ADAMTS13 will normally cleave the protease kind of enzyme, which is going to cleave the von Willebrand factor multimers. So when this ADAMTS13 is deficient, it is going to result in the formation of von Willebrand factor multimers. So the multimers are directly there. So this one deficiency of ADAMTS13 can either be a congenital defect or it could be because of autoantibodies forming against this ADAMTS13. So this defect is called as Upshaw-Schulman syndrome. So Upshaw-Schulman syndrome is nothing but congenital form of TTP. So when these von Willebrand factor multimers are formed, so without a need of endothelial injury, they can directly cause spontaneous platelet activation. So spontaneous platelet activation forms the pathogenesis for this TTP, right? So von Willebrand factors are directly going to activate the platelets. So when platelets are activated, multiple thrombus are going to form in the small vessels and the same story continues, right? Here again, it is going to result in the multi-organ failure, but here it is more CNS involvement more common than the renal, okay? So CNS is much more common. So renal was much more common in HUS. CNS is much more commonly involved in TTP. In fact, there is going to be a pentad of symptoms in the TTP. So even though this pentad is not going to be diagnostic nowadays, because there are patients without forming the pentad. So classical pentad is actually fever, microangiopathic hemolytic anemia, then they are going to have thrombocytopenia, then they are going to have renal failure resulting in oliguria, and then they are going to have CNS defect, CNS kind of complications, especially confusion kind of thing, okay? So this forms the pentad actually. So again, features related to anemia can be there, features related to multi-organ failure is going to be there, then features related to thrombocytopenia, petechial hemorrhage is going to be there. So the most important thing is CNS involvement and renal involvement in HUS, right? So treatment wise, what we do is you have to do a plasmapheresis, and it can be useful only for autoantibody formation. So here we saw congenital and autoantibody, right? So unless you give a ADAMTS13 replenish it, you are not going to you cannot help it. So for conditions wherein autoantibodies are formed against this ADAMTS13, you can do a plasmapheresis to remove the autoantibodies. So what are the findings in microangiopathic hemolytic anemia? So it is an anemia, so hemoglobin levels are going to go down. There is thrombus formation, so consumptive thrombocytopenia is going to be there, so platelet counts is going to go down. In the peripheral smear, if being a microangiopathic hemolytic anemia, you are going to see presence of schistocytes. So schistocytes are these fragmented RBCs which are having this triangular shape or helmet shaped RBCs, okay, fragmented RBCs. So classically schistocytes, we use the term only for microangiopathic hemolytic anemias. So when platelets are down, so platelet count is down, so obviously the BT will be elevated. So bleeding time is going to be elevated. And if you see the PT and APTT here, it is going to be normal